Thank you very much, Emma, for that kind introduction. I'm delighted to be able to join the conference this year. And as you say, I'm live, and I'm not going to use slides. I'm just going to discuss the novel treatments that we hopefully will have available for us in the coming years for, in particular, dry macular degeneration and the severe end of that, which is geographic atrophy. Hope for the future, I think, is your title of this year's conference, and I think there is hope for the future in terms of dry macular degeneration. As you're aware, many of your members will be afflicted with other conditions, including wet macular degeneration, and we've had treatments available now for wet macular degeneration for over 2 decades, in terms of originally photodynamic therapy, and then injections, and then newer injections as the years have gone by. And we've been able to make a big inroad into making a difference in wet macular degeneration, in stabilizing the disease, getting some improvement, and keeping people functioning and seeing as to the best of their ability. And we've been very pleased with what we've been able to do. There's still a lot of work to be done on wet macular. But for all of that two decades of work, we've only made a small impact on dry macular, and we've been looking for a long time at how can we help treat the patients and your members of the Macular Society who are afflicted with dry macular. Now, it's important to put it into scale. We know wet macular degeneration has made a big difference to eye units. The numbers of patients we see coming through on a regular basis now. Treatments for the severe forms of dry macular degeneration are in the same order of magnitude. For people who develop the advanced form of geographic atrophy, it's approximately about 40 to 45,000 per year in the UK, which means for today alone, there'll be around about 100 to 120 patients affected with geographic atrophy every single day, every single year. And so we do have to find an answer, and that's where there's been a lot of interest and a lot of work, and you're going to hear that a little bit from myself and some of my colleagues speaking this afternoon. So what exactly is dry macular degeneration? Well, the full understanding of the pathology is not completely understood. What we think is the most common problem is that the back of the eye, which picks up images, sends them to our brain, is a very metabolically active part of the body. And so therefore the cells at the back of the eye are working all the time, even when we're asleep, continually turning over, lots of energy, very, very metabolically active. You need nutrients coming in, you need those nutrients removed. And with time, the removal and the byproducts of all that activity at the back of the eye can build up. And what happens is you appear to get a buildup of these byproducts, and we often refer to those as drusen at the back of the eye. And these are little creamy yellow little dots. They don't affect your vision dramatically at that stage, but they're a sign of dry macular degeneration developing. And if that process progresses, then what happens is that buildup of those products, those buildup of the drusen, appears to cause an inflammatory reaction at the back of the eye. And we think that's because the body's trying to get rid of those products. It's almost a wound healing response. So you've got something building up, the body wants to get rid of it, a wound healing response from the body tries to get rid of those buildup of products. And that's one of the key areas of interest, has been how to manage that inflammatory reaction, that wound healing process. And that's what I'm going to spend a little bit of time on, because that's where a lot of the interest is at the moment. Now, what happens with this continual buildup of products, this inflammatory action, is that ultimately cells at the back of the eye die, and therefore the cells that are picking up the sight and sending the images to the brain die off, and you get so-called atrophy. And within the macula, you have a central part which does the main part of the seeing, is the fovea, and the atrophy tends to occur around the edge of the fovea. So you get patches, little islands of worn out areas. And with time, those small islands get bigger and bigger, and they join up to one big island, and then gradually they take away the center of the vision. And that's why many of the patients we see, those 100 and 110 patients every day, presenting with this geographic atrophy. It's geographic because these islands, and you can almost draw a line around them as if they were an island on a map. So that geographic atrophy is the worn out areas, which is the end product of all this build-up of products, this inflammatory action, the death of the cells, and then these patches of atrophy. And that's why patients who we see struggle with seeing with geographic atrophy, because the cells are dead. And so you might have a healthy part of retina, and then as you're reading along, your eye comes into this worn out area, and patients are struggling to see the letters. They're not sure. The example I always use is trying to read the word Mississippi. You start with the M, you look at the I, and then you come into the patch of atrophy, and the patients can't see the S, and they're not sure. So they go back. Do they look at the I? Do they look at the P? And then they're not sure where along Mississippi they are. And so therefore it becomes very laborious for people to read, very laborious for people to try to do any everyday actions. And so that's what the problem and the pathology that we're trying to aim our treatments at is: can we stop the buildup of these products? Can we stop the inflammation? And can we stop the death of the cells? And there have been lots of interest in this because of the number of patients affected on a daily basis. So one of the things that's been, I'm going to tell you 3 areas. There are many, there are numerous, like there are literally 30, 40 trials going on in the world at the moment on lots of different avenues of attack of how we can alter this progress. But I'm going to concentrate on 3 main ones. 1, because it's relatively simple to deliver and provide some hope. 2 is light therapy, which is very much being marketed a lot in the UK at the moment. So I want your members to be aware of exactly what the light therapy is. And then the 3rd thing I'm going to concentrate is on complement inhibition. That's what that is drugs to try and stop the inflammatory reaction occurring. And the reason why that's important is that these drugs are going through regulatory processes in the UK and in Europe as we speak, and are already approved in the US. So many of your members, if they lived in Boston or New York, would be able to have treatments for geographic atrophy available today. But in the UK and in Europe, they're not available as of yet. But we're hoping that the regulators will consider them, and we're talking within the next few weeks and months. So that's where the real interest is. So those are the 3 things. There are many others, and I'm quite happy to take questions on many of the other treatments. And you're going to hear a little bit more later on in the afternoon about potentially reversing some of the very serious defects. But one of the first things is this oral vitamin A. So we know vitamin A is needed for the eye to help patients for our normal eye functioning. And with vitamin A, it's produced, it goes through this metabolic process to allow us to, the light processes occur at the back of the eye. And then it's broken down into a so-called dimer, which is a molecular change. And that molecular change means it's more difficult to remove it. And so therefore it builds up. So one of the areas of interest is, well, can we give a vitamin A that doesn't form these dimers and doesn't therefore build up? And there have been now oral changes to the standard vitamin A tablets can be altered so that they don't form these dimers. And there's a lot of interest in this because it's very easy to give. It's a tablet once a day. It doesn't appear to be affecting the normal visual processing, so people are seeing okay with it. And therefore, if you can still see well with it, easily taken on a daily basis and help prevent the buildup of these products, then that can make a big difference to people. There are clinical trials in their late phases at the moment going on, and the original trials did show some early encouraging results. It's also been used for other macular diseases as well as age-related macular degeneration. It's been used in Stargardt's disease, and I'm sure you've had webinars on Stargardt's disease recently, which have been addressing some of these similar products, these oral vitamin A new treatments that can hopefully alter the buildup of byproducts at the back of the eye. And that can be for patients with inherited disease like Stargardt's, but it can also be for geographic atrophy. But we're not there yet. We need to wait to see the results of those phase 3 clinical trials. We need to know who benefits, when to give it, how to give it, what to look for when we're treating patients with it. So it's not as simple as, well, let's just use this. We have to make sure it's safe, and we have to make sure it's effective. So oral vitamin A, deuterated vitamin A is an area of interest, and I would hope that your members keep an ear out for that. over the coming 1 to 2 years. These are the phase 3 clinical trials are already there. Now, another treatment that has received a lot of interest recently is light therapy. And what light therapy is shining lights of different wavelength into the back of the eye to try and stimulate processes at the back of the eye. Now, we know that light therapy works in certain conditions. If you think about it, we all have light therapy in developing vitamin D in our bodies. So we have to be out in sunlight to receive the photobiomodulation from the sun. We absorb that light, and that helps our processes, keeps us healthy, keeps producing our vitamin D. So photobiomodulation or light therapy is not a new concept. It's a biological process. But what we've been trying to do more recently is seeing if light therapy can affect cells at the back of the eye to try to give them a boost. And what we believe is happening as the cells at the back of the eye, as they age, their energy systems, their manufacturing energies, fuel cells, the mitochondria within those cells become labored and tired. And so what we believe light therapy may be doing is stimulating those mitochondria, those fuel cells. And by stimulating those fuel cells, you keep the pigment cells, the retinal pigment epithelial cells, alive for a lot longer, and therefore they're less likely to run into this atrophy where they die off. So you're basically stimulating the fuel cells within the retinal pigment epithelial cells at the back of the eye and preventing them, as I say, atrophying and dying off. And there has been some early preclinical work showing that there is some potential benefit and that we can see improvement in retinal function by stimulating those cells with a certain wavelengths of light. And there have now been clinical trials where patients get exposed to the light therapy for a short amount of time. And the trials that have been at the moment have been in the region of 3 treatments a week for 9 weeks. So you have 3 1 week, 3 next week, 3 the next week. So 9 treatments over 9 treatments over 3 weeks. And then you repeat it 3 times a year. So every 4 months, you have the same 9 treatments again. Now, in the clinical studies that have been done, there has been some interesting effects where the patients who are exposed to the light seem to get a small improvement in vision. And that's very encouraging. And this has made people a lot of excited around the world about, can there be something that we can use here to try to reduce the impact of dry, advanced geographic atrophy in patients. And the studies that have been done are studies called LightSight 2 and LightSight 3. And they have shown these encouraging results. But the problem is that it's only in a very limited number of patients. And in LightSight 3, which is the most recent study, there were only 90 patients who actually received the treatment. And there were 60 patients who didn't receive the treatment and were comparing one group to the other group. Well, the problem with geographic atrophy and dry macular degeneration is it's a very wide-ranging disease. And so when we do clinical studies in a disease that comes in lots of different forms and, progresses at different rates, then we need hundreds and hundreds of patients to be able to see whether there is a true effect. In the studies that have been done with the light therapy as of today, there's only been a limited number of patients. And so there's a concern that the results we're seeing are not actually true, and they're actually just due to chance. And that can occur when you're using small numbers. And generally, when you do clinical trials, you have to identify this problem right from the beginning. The more heterogeneous, the more varied the presentation of geographic atrophy is in patients, then the more patients you need to be sure that what you're seeing is a true effect or just by chance. And that's one of the concerns with the light therapy, is that it's been in a clinical trial with 90 patients in the LightSight 3 who have only had the treatment, and we don't know is the results that we're seeing, are they just by chance? Are they different groups? So if one group of patients who are not having the treatment actually had a better starting outcome, then they're more likely to get a better outcome. And because of that, there is a lot of amongst ophthalmologists like myself around the world. Now, We believe it needs a lot more investigation in clinical trials, and we're very, very keen to support that. I think many of my colleagues would be very keen to support light therapy within clinical trials and to see it and study it properly. But the way it's being marketed in the UK is slightly different. It's being marketed because it's not a drug and because it's not a laser. It's actually just a LED light of a certain different wavelengths. It's a multichromatic light. It's not a laser, so it's not going to cause the same damage. And so therefore it's not regulated the same. And because it's not a drug, it doesn't go through the same regulations. So it's being brought to market a lot easier, which may be good. And that the advantage of that is it brings it to patients earlier. But one of the disadvantages is that it can be gone without the full scrutiny. And one of the concerns we have is that it's being heavily marketed as an approved treatment. And the problem is it's not really approved. It depends. If I was a patient and I saw a treatment being approved, I would assume that it had been gone through a full regulatory body and people would have sat down and experts would have considered the evidence and said, yes, we believe this works. When they're marketing it as approved, what they actually mean is that the LED light that's being shone has got a so-called CE mark. Well, your kettle has a CE mark. My lamp in my room has a CE mark. What that shows is that it confirms to a certain level of manufacturing, and that it's unlikely to cause you harm because it goes through those manufacturing processes. But the actual benefit is not necessarily a part of the approval process. And so when we see it marked as approved, it's important to make clear that that hasn't necessarily been approved by a body of ophthalmologists or the Royal College of Ophthalmologists or the MHRA who looked at drugs. They haven't seen the evidence. They haven't made a decision or a comment on the evidence per se. So approved, I think, is a difficult word that's used for it. And in some marketing, it's considered as a permanent treatment for dry macular degeneration. And again, the evidence for that is minimal. So I think light therapy is interesting. I think there's an element of further research that needs to be done to identify exactly how it would benefit people, when to give it, how often to give it, and are there any long-term risks? And are we then missing things because we're not we've got this false sense of security? So I think there's a lot needs to be done on that. Now, the last thing I'm going to talk about is the complement inhibitors, as they're called. And these are drugs that we have been studied in full clinical trials to try to stop the inflammatory process, which leads to these death of the cells and the geographic atrophy occurring and the subsequent loss of vision. There are two major products that have hit the market in the US in the last 2 years. One of them is Syfovre, and one of them is Izervay. I'm going to speak a little bit more about the Syfovre because that's the one that's slightly further ahead. That's the one that we've got more experience in the UK because we were part of the clinical trials going on around the world. And in Liverpool, we were the primary centre, the chief centre for the study, so-called Oaks and Derby study of these treatments. So what are these treatments? What do they do? Well, what they are, and remember I've said to you, you've got build-up of products at the back of the eye that cause an inflammatory reaction leading to death of cells and the atrophy. So if we can stop the inflammation, that would help. Now, one of the controlling mechanisms in our body for controlling inflammation is called the complement system. And that's where our cells release certain chemicals to prevent the inflammatory processes running wild. So if you do have an injury, you need inflammation, you need repair, but then you need that repair to stop. And so therefore you have this complement system, which stimulates the system. And when the healing and repair is done, it calms the system back down again. And that complement system is throughout the whole biological world and has been studied for many, many years, and we're learning more and more about it. It appears to be a cascade of certain inflammatory markers and inflammatory controlling molecules in the eye, in the body. And it's a complex system, but there have been two major targets that we've been interested in. There's one of the molecules is C3, so complement 3, and the other one is complement 5. Complement 3 is the one where the latest drug, the Syfovre, is aiming its attack at. What we believe is you have the build-up of products, you get an inflammatory reaction, the inflammatory cascade occurs, and that leads to the death of the cells. So if we block this complement 3. So we take a complement 3 inhibitor and we block that area, we stop the inflammation occurring. And that's what we're doing in treatment with Syfovre. But how do we get that complement to those inflammatory cells at the back of the eye? Well, unfortunately, the eye is developed and has evolved over millions of years to prevent things getting into it. We don't want infections in the eye. We don't want things damaging our retinal and our circulation. So the eye has been developed to stop things getting in. And at the moment, one of the best ways of getting things through that defense mechanism is unfortunately passing it through a needle actually into the vitreous cavity. And that's what we've been doing with wet AMD for many years. But unfortunately, we're having to do it with geographic atrophy as well to deliver these complement inhibitors. So what happens is we take the complement inhibitor in a syringe, we inject a tiny amount in the eye, it spreads through the eyes, it calms down the inflammation by blocking this, this molecule C3. But then again, it wears off, and so therefore it has to be repeated. And in the studies, we gave injections every month or every other month. So you either have it every month or every 2 months. Now, the studies have run their course. The major phase 3 clinical trials with pegcetacoplan or Syfovre were known as the Oaks and Derby trials. And those Oaks and Derby trials showed that there was a modest but definite reduction in the size of the atrophic area, these death of cells. There was a modest reduction. Now, it is a modest reduction, and that's important to be aware of. We believe the worn out areas grow on average about 2 millimeters squared every year. Now, 2 millimeters squared is a tiny amount, but it's enough if it's close to the center of the vision to take somebody from reading to not reading or driving to not driving, because of small changes at the back of the eye make a big difference to our visual system. So the average patient grows or has development of the atrophy by about 2 millimeters squared per year. So you go 2, 4, 6 over 3 years. Now, if we give Syfovre, the injection in the eye, then what happens is you don't stop the geographic atrophy. You don't stop the dry macular degeneration developing, but you seem to put reins on it. You slow it back. And the results appear to be showing that we're slowing it by about 20 to 30%. It depends exactly how you define it. But you're slowing it down a little bit each year, and then that seemed to be a cumulative effect. So what, by the end of 3 years, instead of going 2 millimeters growth, then 4 millimeters, then 6 millimeters, we slow it down by 2 millimeters over that whole period. So actually, instead of being at 6 millimeters you've now only lost 4 millimeters. So you've still lost vision, you've still lost cells, but you've slowed it down. And the way I think of it, and there is arguments for and against it, but as a general rule, I think we're slowing it down by about a year for every 3 years of treatment. But that is a treatment every month or every other month for 3 years, and it's going to be continued. So it's a lot of burden for the patient. It means coming back. It needs regular monitoring. It means a lot of an injection each time. But as we know from wet AMD, patients tolerate the injections very well. It's a few, sounds terrible every time you have it, but few drops in the eye, lift the eyelid, small injection. Patients manage it very, very well, remarkably well. And so although it is a burden, it is well tolerated by patients, but it will need to be continued. And it is a modest effect. It's not stopping the disease. But what we hope it will do is allow us to slow down the disease until better treatments come along. And whether that be these oral vitamin A's, or there's lots of other treatments where we're looking at stimulating the cells through mitochondrial enhancers or certain genetic studies to try and affect the disease process. We need something now in 2024 to slow down the progression for those 110 patients who are presented every single day. And that's where we believe Syfovre and this other product, which is Izervay, which affects the inflammatory cascade, but a little bit further down at a molecule called C5. But the studies for that are a little bit further behind, of basically about 6 to 9 months behind the Syfovre studies. So what I'm saying for Syfovre is very similar for this other drug that's coming up on the rails. Now, why is this important for us? It's important for us because if you lived in Boston or New York or Chicago, today, you could go to your ophthalmologist and receive it, because the FDA, which is the regulatory authority in the US, have approved both Syfovre and Izervay. Now, Syfovre was actually approved 18 months ago. So in the US, for the past 18 months, there's been treatments. Again, as I say, modest, and I'm going to talk a little bit what are some of the side effects of the treatments in a moment. Now, what's happening in the UK is that prior to Brexit, we were part of the European Medical Agency, and so therefore a drug that was coming to market would go to them. They would look at the safety and the efficacy and decide whether it could be brought back to be regulated and approved. And then within the NHS, we would decide whether we can afford it through NICE. But the regulatory approval, the licensing of the drug, would go for the European Medical Agency. Well, we've now, since Brexit, moved out of the European Medical Agency. And so now we have our own agency called the MHRA, and they are presently looking at the regulation of Syfovre. Now, they haven't made a decision at the moment. The Europeans have looked at it, and initially they've said no. And there's been a bit of a debate about whether that's a good, because you've got the American regulatory authority saying yes, it's suitable to be approved, and the Europeans saying we're not sure about the effects of it. Is it good enough? Now that's going to appeal, and we're hoping to the decision of that appeal in the next 1, 2, 3, 4 weeks. We're talking weeks for the Europeans to make a decision. Now they may say yes, or they may say no, as they've done on previous occasions. The MHRA will hopefully, once they know that decision and whether that should influence them or not, but we hope they're making their own assessment of it. And then in the next few months, we will hopefully have an announcement as to whether the Syfovre, which is available in the US, will be available in the UK imminently. Now, that will make a big difference, because that will mean there will be an approved treatment in terms of it's been approved for a regulatory process, available for the first time for geographic atrophy in the UK. That's going to be of interest to many, many people, but it doesn't mean many, many people will benefit from it. I think the important thing is if it does get licensed, we have to be sure we're giving it to the right people at the right time and monitoring those patients carefully. And so therefore we need to make sure that it is delivered appropriately. The reason partly for that is that there are risks with the treatment. With any injection we give you, and remember it's going to be an injection, we don't know whether it will be every month or every other month. My gut feeling is it will end up being every other month, about 6 injections each year. But when you give an injection, there's always a risk: infection, hemorrhage, retinal detachment. You're breaching the surface of the eye, so there's always a risk. That risk we know is very low. We believe it's around about 1 in 2,000 of a serious infection, or 1 in 3,000 of serious infection of giving an injection in the eye. And we've had that with wet AMD, and we've been able to manage it over the years. So we're comfortable with that, but patients need to understand that there is a small risk. And if you get an infection, you will lose the whole of that vision in that eye. In general terms. Other problems is that the treatment appears to calm down the geographic atrophy by a small amount. Remember, probably saving a year over 3 years. It also carries a risk of increasing the risk of wet macular degeneration, because that again is also an inflammatory process, and it's carefully balanced. We believe that it almost doubles your chance of wet macula. So when you've got dry macula, you have about a 3 to 4% chance each year of developing wet macula in that eye as well. And what happens when you have this treatment is you may double that. So you might go from 3% to 6% in 1 year. Now, that's still a low number. 6% is still, 1 in 20 patients. It's not, 1 in 18 patients. It's not a high number, but it's an important number if you're the one who gets it. We can treat wet macula, remember, and because if you were receiving the dry macular treatment, you'd be watched very closely. We'll be looking out for wet macular degeneration each time you come. So there is a risk, and you need to be aware of that. So patients who may have had lots of wet macula in the past, they may not be the ideal patient. Now, if they've been well controlled and they've done well with it, then yes, you could treat the dry, but you have to be aware that you might be triggering off the wet again. That's a key thing for us as physicians to be aware of, but it's also very key for patients to be aware of when they're going for a new treatment. Everybody wants the new treatment because there has been nothing. So obviously there's a natural tendency to want it, but you do need to be aware of these risks, and you need to have a physician who's experienced in understanding these problems and being able to manage them if and when they arise. So that's one of the key things. So you've got the risk of injection, the infection, which we've had for lots of treatments, but you're very low, 1 in 3,000. You've got this risk of triggering off the wet. So you've already got a risk, you're just making that risk a bit more. And then in a very, very small number of patients, when it was licensed in the US last year, there was some severe inflammations, and they were very severe, with some patients losing vision. Now, we believe, now that it's been available in the US for about 18 months, that figure is somewhere in the region of about a 1 in 10,000 risk. It's a very low number, but it means nothing if you're the one person in 10,000, because if you get a severe inflammation in your only good eye, then that can be a concern. And again, what's happening in the US is sometimes what they're doing is going, well, there's a very rare risk. So what we'll do is we'll do it in the bad eye first, see if you have that response. If you don't have the response, then they'll be more confident of giving it in the good, the better seeing eye. So again, these are all subtleties that will need to be decided by us as a group of physicians. And we hope we'll get some consensus within the UK from people like myself who deal with geographic atrophy and wet AMD on a daily basis, and involving patient groups to try and get some input as to where the risk should lie. But what we hope is we'll get some consensus about how to deliver this treatment should it receive approval. And as I said, the Europeans have said no at the moment. It's gone to appeal, and they might be saying a different decision, or we'll wait that decision in the next few weeks. And the UK decision we expect will be soon after, within the next few months. And if they are approved, then we need to be delivering them to the people at the appropriate time in an appropriate way, with fully understanding the implications of treatment versus no treatment. And I think that's the key if it becomes available. And I think that's what fits the hope for the future. There is hope for the future. It's a modest effect, but we need a modest effect because we've got limited effects at the moment. We get a modest effect until something better comes along in the next few years. Then that's a step forward in the right direction for us and for many of your members. So I think there is hope for that. What can you do in the meantime? Well, I think you need to make sure healthy green vegetable diet. Those are the common things. You know about the vitamin supplementation. There's the effect on geographic atrophy is more limited than we see in wet macular degeneration with vitamin supplementation. But again, take advice from your ophthalmologist or experienced optician. When you go to the optician, I think it'd be wise to try to see if you have got dry macular degeneration, that the optometrist or the optician can take a scan of the eye, make sure that they can see what the state of the eye is as of today, and then either provide you with the copy or keep the copy, or what I recommend my patients is if the scan's up on the screen, take a picture on your own smartphone so that you've got it in your own records should you go to see somebody else later on. And the reason why that's important is the people that we think will most likely benefit from this treatment will be those who have got rapid progression of their geographic atrophy. So if you're progressing rapidly, then you're more likely to benefit from the treatment. So how do we know if you're progressing rapidly? Well, if we can look back at your optician's records or your hospital records, then that will be helpful. So my advice is, if you do see your optician and you have dry macula, a scan of the back of the eye is very helpful. That helps us know where it was on, today on the 14th of September 24. And so if you come in May next year, we can see roughly how it's progressed. So that's important. And I would say that is something that we should be doing now. And then I think you should be checking on your own vision. When you've got both eyes open, it's always difficult to know, is one deteriorating? So I always recommend patients once a week, cover one eye. Cover one eye. You can use the Amsler chart, which is that grid to look for distortion, but in my mind, the whole world's made up of straight lines, whether it's be doorways, windows, mirrors. So I just make sure you cover the eye once a week and look at a straight line. And if there is an area that is newly distorted, then you should seek help from your local optician or ophthalmologist within the next week to see, is there a reason for why that new distortion? Of course, if you've already got distortion, it's not always easy to know if that's getting worse. And again, if I tell patients, if you think it's okay, it'll probably be okay. If you think it's not sure, probably see your optician. If you think, oh my goodness, there's something different, then you really need to see somebody within the week. And it's the covering of the eye for a few moments, once a week. Don't be paranoid, just be vigilant for doing this once a week to just see if there's any sudden change in the central vision. And the importance of covering the eye is because the other eye can be compensating, you're not aware of it. So I think good optician, good scanning, recording the scannings, keeping the scans yourself on your own smartphone or getting a handout from the optician will help in the long term at knowing where we're going forward, to know whether you are likely to benefit from some of the treatments that may be coming forward in the next few weeks and months. So it is a may. The MHRA may say no, and in which case we're not going to have access, and we will keep looking for new treatments for patients and that we see on a daily basis. So I think that's been a quite comprehensive review of where we are. I've not covered everything, and there are many other different treatment areas, but I think those are the three that interest to me. The oral vitamin A, because I like the delivery, it's a simple delivery, and there's been some good results with Stargardt's disease, which is an inherited disease, but has similar changes that we see in age-related geographic dry macular degeneration. So I think the oral vitamin A is something we should keep an eye on, but we'll need to see the clinical trials. I think the light therapy is interesting, but I think needs a lot more work before I would recommend it. I choose not to give it at the moment because I think we need more evidence for it. But I think the complement inhibitors, these injections, whether they be with Syfovre, the one that's been licensed for 18 months in the US, or Izervay, which is the one more recently, both of those we hope will go through regulation. And those will be a hope for the future if we can get them to market. Then we've got the whole issue of whether they'll be available on the NHS, but that is a separate issue. First thing we have to do is make sure that we've got access to them. So thank you, and I'm very happy to take any questions or anything I've discussed this early afternoon.